Hi, everyone. I'm Eugenia Gianos, Director of Cardiovascular Prevention at Northwell Health, Director of the Women's Heart Program at Lenox Hill Hospital, and Professor of Cardiology at Zucker School of Medicine. I am joined today by my colleague, Dr. Guy Mintz, who is the Director of Cardiovascular Health and Lipidology, also the Director of Lipid Apheresis at North Shore University Hospital at Northwell Health, an associate professor of medicine at Zucker School of Medicine, and lastly, our current president of the Northeast chapter of the National Lipid Association. So we're really excited to have you here tonight to join us for this talk about lipoprotein apheresis, specifically in high-risk patients. This is such a core topic that unfortunately is not always addressed in usual medical curriculum in a lot of different areas. And there's so much for us to learn to guide our clinical practices and to potentially optimize a lot of patients out there who are at high risk for cardiovascular events. So for tonight's event, the CME credits are available through Opus Medicus, who designate this activity as a 1 AMA PRA category credit and 1 ABIM MOC point. You'll see at the end of the talk that there will be information about how to claim your credit. And we'll also be entertaining questions at the end of the talk. So any questions you may have, please put into the Q&A box, and we'll be excited to have a very heated discussion afterwards. So Dr. Mintz, thank you for joining us, and we're excited to hear your talk.
Thank you, Dr. Gianos, and I'd like to thank everyone for joining us this evening. So we're going to talk about the role of lipoprotein apheresis in high-risk population. Now, when we talk about coronary artery disease, peripheral arterial disease, or cerebral vascular disease, what we're talking about here is manifestations of the same disease state, atherosclerosis and various vascular beds. But I also want to highlight for us this evening the role that lipoprotein A plays and familial hypercholesterolemia play as risk multipliers in this population. So with tonight's presentation, we're going to learn the definition of what is a high-risk cardiovascular patient. We need to understand the risk of familial hypercholesterolemia, elevated lipoprotein A on coronary artery disease, peripheral arterial disease, as well as stroke. We need to understand the role of lipoprotein apheresis in this high-risk population and how apheresis can be used as a treatment option in this population when standard medical therapy has been unsuccessful. So we all know that atherosclerosis and artery stenosis are driven by high LDL cholesterol, oxidized LDL cholesterol, and lipoprotein A, which change the endothelial milieu and allow for the progression of atherosclerosis and plaque propagation, ultimately leading to a thrombotic event and end organ damage. So we understand that our high-risk populations may be amenable to apheresis, and these high-risk conditions, such as familial hypercholesterolemia, may be appropriate for apheresis in patients where medical therapy has been unsuccessful. Apheresis may also be appropriate in certain patients with elevated lipoprotein A, and certainly when taking the two conditions of family hypercholesterolemia and elevated lipoprotein A in consideration with coronary artery disease and peripheral arterial disease, you'll see that there is a role for lipoprotein apheresis. Now, when it comes to familial hypercholesterolemia, many of us can identify these patients just by chart rounding or looking at our daily labs. Consider patients to have familial hypercholesterolemia if you see an LDL of greater than 190 milligrams per deciliter. The target LDL for treatment of this population in primary prevention, those without atherosclerosis, is a target LDL of 100 milligrams per deciliter or less. These patients may present with corneal arcus, tendinous xanthomas, xanthelasmas, and they require high-intensity statin therapy with initiation of therapy because of the high cardiovascular risk associated with familial hypercholesterolemia. Ezetimibe can be added to achieve that target, as well as PCSK9 therapy, as well as bempedoic acid. Evinacumab can be added in patients with homozygous familial hypercholesterolemia, and certainly there's a role for lipoprotein apheresis. Now, when it comes to familial hypercholesterolemia, it's more common than you think. 1 in 250 Americans can have familial hypercholesterolemia, and 90% of those patients have not been accurately diagnosed. Untreated familial hypercholesterolemia patients can have 20 times the risk of developing coronary artery disease compared with the general population. And you can see in the lower right that only 52% of patients with familial hypercholesterolemia achieve an LDL cholesterol goal of less than 100 milligrams per deciliter. 78% of patients did not achieve an LDL cholesterol target of less than 70 milligrams per deciliter. And it's important to screen the first-degree relatives of these patients. Each child has a 50% chance of developing familial hypercholesterolemia. And as I said, you need to consider the siblings and children of the person diagnosed with familial hypercholesterolemia and identify all first-degree relatives that could be at increased risk. Now, interesting enough, in work done by Demansky here, you can see that patients that are exposed to very high levels of cholesterol from a young age develop early onset of atherosclerosis, and those with moderate hypercholesterolemia, starting in the teens, whether it's due to genetics or lifestyle, also have an earlier threshold of developing atherosclerotic disease. And finally, those patients with modest hypercholesterolemia, starting from adulthood on, also will have an earlier onset of atherosclerotic disease. Patients who have genetic predisposition to low LDL cholesterol or maintaining a healthy lifestyle or initiation of LDL cholesterol lowering therapy at a younger age have a much later onset of atherosclerotic heart disease. So it begs the question, should we be considering early risk factor modification, including lipid-lowering therapy in younger patients with hypercholesterolemia? Certainly those patients with familial hypercholesterolemia do require aggressive and early treatment for hypercholesterolemia. Now, lipoprotein A, as I said earlier, is a risk multiplier of disease. It's an independent and genetic risk factor for increased coronary heart disease risk, stroke, and aortic stenosis. Lipoprotein A has pro-inflammatory effects manifested by increasing monocyte cytokine release, increasing smooth muscle cell proliferation, increasing foam cell formation, and its pro-inflammatory effect is manifest by the oxidized phospholipids that are attached to the LPA molecule. And it has a prothrombotic risk because of its decrease in plasminogen activation, decrease in fibrin degradation, because it binds to fibrin and interferes with the conversion of plasminogen to plasmin, and structure similar to plasminogen allows for that. So this also contributes to increased risk of thrombosis. So in patients that have a strong family history of early atherosclerotic disease, patients with familial hypercholesterolemia, patients with recurrent cardiovascular events or premature aortic stenosis should all be screened for lipoprotein A levels. In fact, European guidelines recommend that all adults be screened at least once for a lipoprotein A measurement. In the 2018 cholesterol guidelines, elevated lipoprotein A of greater than 50 milligrams per deciliter or 125 nanomoles per liter is considered a risk-enhancing feature. Therapy for lipoprotein A is limited to lipoprotein apheresis. LDL reduction can lower LDL cholesterol, but as you'll see, may have increased effects on lipoprotein A. PCSK9 can affect lipoprotein A, as well as niacin. The future is bright as we're working on antisense oligonucleotides and small interfering RNA molecules, which will lower lipoprotein A. And we've seen data from the United Kingdom Biobank data set of 460,000 patients that increasing levels of lipoprotein A are associated with increased atherosclerotic cardiovascular risk in a linear fashion. No difference when we look at the data from the Copenhagen general population and city heart study. Increased lipoprotein A is associated with increased risk of myocardial infarction. And then when you combined familial hypercholesterolemia with elevated lipoprotein A, you get a significant increase in atherosclerotic cardiovascular events. You can see this group in blue over here having a very high risk of events. The group below that in orange is represented by those patients with elevated lipoprotein A of greater than 50 milligrams per deciliter. The gray line is familial hypercholesterolemia alone, and the orange line is neither FH or elevated lipoprotein A. But adding lipoprotein A to familial hypercholesterolemia is associated with a very high risk of atherosclerotic cardiovascular events. Now, peripheral arterial disease is a cardiovascular risk equivalent. Symptomatic patients with peripheral arterial disease are at very high risk for increased cardiovascular morbidity and mortality. Interestingly enough, in the 4A trial, which looked at PCSK9 inhibitor evolocumab in patients with coronary artery disease, a group of patients with symptomatic peripheral arterial disease was evaluated. Out of the 3,600 patients, 1,500 patients had no prior myocardial infarction or stroke, and there were 23,000 patients that had prior MI and stroke. And when they looked at the group with the symptomatic peripheral arterial disease, there was a significant increase in the primary endpoint. 16.8% of patients with symptomatic peripheral arterial disease had increased risk of cardiovascular death, myocardial infarction, stroke, hospitalization for unstable angina, or coronary revascularization, compared to the 12% of patients with no peripheral arterial disease. And these were patients that were on high-intensity statin therapy. If you look at the graph on the right, this is data from the Pegasus trial, which looked at ticagrelor and aspirin as dual antiplatelet therapy in post-MI patients on maximal tolerated statin therapy and other agents. And the group with peripheral arterial disease had a significant increase of events, 19.3% versus 8.4% in the patients that had no peripheral arterial disease. So if you look at both trials together, you had patients that were maximally managed, high-dose statin therapy, PCSK9 therapy, and on the other side, you had dual antiplatelet therapy, but yet these patients that had symptomatic peripheral arterial disease had a greater ischemic burden despite optimal medical therapy. So it's important for us to remember that patients with symptomatic peripheral arterial disease are high risk for subsequent cardiovascular events. And then we start to look at the effect of lipoprotein A added on to these patients with symptomatic peripheral arterial disease. In this data by Tomoy and his group, they looked at patients with peripheral arterial disease following endovascular therapy, endovascular intervention, and they were looking at major adverse coronary events, death, myocardial infarction, and stroke, as well as major adverse limb events. They divided the groups into low lipoprotein A levels of less than 30 milligrams per deciliter and high lipoprotein A levels of greater than 30 milligrams per deciliter. And what they found is that the high levels of lipoprotein A were independently associated with an increased risk of major adverse cardiovascular events and major adverse limb events after endothelial or endovascular therapy. And these results were independent of LDL levels and statin therapy. So just think of that. So here you have LPA levels modulating a higher risk of cardiovascular events and limb events in patients that have had an intervention. So it begs the question that we should be measuring lipoprotein A levels in those patients with peripheral arterial disease, and it certainly reinforces the need for more aggressive therapy for lipoprotein A in this population with symptomatic peripheral arterial disease. Now, we know from other studies that lipoprotein A in other groups of patients, here we can look at the data from the United Kingdom and Scotland together. They show that high lipoprotein A levels in the 75th percentile were associated with a predictor for the development of peripheral arterial disease, and even more so than as a predictor of coronary artery disease. But interestingly enough, in a group looked at by Torero, patients with symptomatic peripheral arterial disease had more clinical events over 3 years than not. So in the patients with symptomatic peripheral arterial disease, you saw an increase in myocardial infarction, stroke, limb amputations, and deaths. Now, interestingly enough, they divided the patients into tertiles based on levels of lipoprotein A levels. The highest level was greater than 50 milligrams per deciliter. Lowest level was less than 30 milligrams per deciliter. And the event rate was significantly higher in the group with the high levels of lipoprotein A, with 23% having a myocardial infarction, 64% having a stroke, 23% having a lower limb amputation, and 33% having any of the three conditions. So again, more evidence that lipoprotein A is a risk modulator, a multiplier of risk in patients with symptomatic peripheral arterial disease. So when we look at these patients that have progressive peripheral arterial disease on optimal medical therapy, certainly lipoprotein A should be tested. It's a simple blood test. You add it on to the lipid panel you're doing in the office or whatever blood testing you're doing that day. You should also note that patients with coronary artery disease or cerebral vascular disease should be screened for peripheral arterial disease in the setting of elevated lipoprotein A, since polyvascular disease portends a worse prognosis. And as I showed you in the initial slide with the Venn diagram, there's significant overlap between the various atherosclerotic disease states. Peripheral arterial disease patients with elevated lipoprotein A who develop progressive disease to symptomatic peripheral arterial disease, limb ischemia, or the need for revascularization should certainly be considered candidates for lipoprotein apheresis. Now, what is lipoprotein apheresis and how it works? Very simply, first off, it's a venous procedure. So it's not dialysis, it's a venous procedure. And what you're doing, you have two peripheral lines, and you're withdrawing blood from the first line, and you're separating ApoB containing particles based on charge. What you're seeing here is the lipoabsorber apheresis system made by Canica. That's the system we use in our center. You're separating LDL, lipoprotein A, VLDL, using the absorption columns. The lipid profile, the lipid components are taken out, and then the blood is warmed and returned to the patient. And the waistline represents the cholesterol that we take out of the patient. And then there's regeneration between the columns, for the columns, so we can withdraw more blood. The treatment takes 2 to 4 hours. At our center, we found that peripheral access became a problem, as it is for many of the different centers across the world. So we changed for our patients to using central line, a subcutaneous tunnel line with a barred power flow port, which allowed us, one, to accelerate the process. So we're finishing our patients in less than 3 hours. Number two, it gave the patient access to use their arms during the procedure, because using bilateral peripheral IVs, they didn't have access. And as I said, we lost access a few times with the process. So now we have a comfortable process for the patients, and they can tolerate the procedure without difficulty. This is some data from the United States with regard to lipoprotein apheresis, and the biggest side effect, if you will, is venous access issues. But overall, the process is well tolerated. There's not any significant blood loss for the procedure. Patients very comfortable during the procedure, and they're able to go home afterwards without any issues. In terms of current interventions for the treatment of lipoprotein A, lipid apheresis is by far the most effective treatment for lipoprotein A, and you get a 70% reduction in the lipoprotein A in the acute phase of treatment, and then about a 35% time average reduction over the 2-week treatment interval. There are several longitudinal prospective trials that support lipoprotein apheresis for the treatment of lipoprotein A. nicotinic acid and niacin can reduce lipoprotein A levels 20 to 30%, but due to systemic side effects and a lack of clinical evidence that nicotinic acid lowers cardiovascular events, it's not being used. PCSK9 inhibitors can lower lipoprotein A 14 to 30%. It's a variable effect based on the starting LPA levels, but that's the range. And I'll remind everybody that PCSK9 inhibitors are not indicated for the treatment of elevated lipoprotein A. Statins can increase lipoprotein A 8% to 24%. So if you put your patient on a statin and the patient comes back in and you're going to remeasure lipoprotein A, just make them aware that that's an expected effect of statin therapy. Ezetimibe, bempedoic acid, fibrates have no effect on lipoprotein A. So how does reduction of lipoprotein A and LDL particles reduce clinical events? What's the mechanism of action in terms of lipoprotein apheresis and assisting in these outcomes? And you really see, some of it from reduction in pro-inflammatory markers. And you could see this is data from Pat Moriarty, and you see a reduction in fibrinogen of 20%, reduction in C-reactive protein of 65%. You see a reduction in monocyte chemoattractive protein. You see a reduction in endothelial 1 of 75%, and that's a vasoconstrictor. And it's known that after lipoprotein apheresis, there's vasodilatation. And, all of these put together show that we have a reduction in inflammatory markers, and this may be one mechanism for the benefit of lipoprotein apheresis over time. In this work by Stefanuti from Italy, you see the reduction in interleukin-6 as a marker of reduction of inflammation. You see that initially with the first treatment of apheresis, interleukin-6 is reduced, and it's reduced again with the second treatment. So clearly, lipoprotein apheresis reduces inflammatory markers. Now, you can look at the acute impact of apheresis on oxidized phospholipids. As I said, oxidized phospholipids are attached to the lipoprotein A molecule and are a certain cause of clinical events, with the pro-inflammatory effect, certain contributing factor to the development of aortic stenosis. So in this study here, the groups were divided in based on lipoprotein A levels of low LPA, intermediate LPA, and then high LPA. The top group is pre-apheresis and the bottom group is post-apheresis. So we'll just point out that not only are you lowering ApoB particles, you're lowering ApoA particles, lipoprotein A, as we talked about, but you're also lowering oxidized lipoproteins. So I think this is, an important potential mechanism for us to consider when understanding how lipoprotein apheresis helps patients. This is some data from, again, Pat Moriarty and Sam Smakis that is not published, but they were looking here about oxidized phospholipids attached to the ApoB molecule as well as lipoprotein A. And you can see again with apheresis that you're reducing your lipoprotein A, you're reducing your oxidized phospholipids here attached to the ApoB. So more to follow on that. Also, we've seen that there's a reduction in the viscosity associated with lipoprotein apheresis. So making the blood less viscous may also be a contributing factor to reduction in clinical events. This is some of the data from our Northwell Health team here, and you could see that after apheresis, we have an 80% reduction in our cholesterol, ApoB-containing particles, LDL, and ApoB, 70% with the next treatment here. And similar to the findings I showed you before from Pat Moriarty's group in Kansas, we've seen a reduction of 70% in our C-reactive protein, 60% on the second treatment. We see a reduction in lipoprotein A, 44 to 50%, and we see a reduction in fibrinogen with our treatment. So again, more evidence that there is reduction in inflammation seen with patients treated with lipoprotein apheresis. So what's been the clinical experience when we talk about patients that undergo lipoprotein apheresis. And here you can see some data looking at the effect of lipoprotein apheresis in patients with familial hypercholesterolemia and coronary artery disease. So in this group, lipoprotein apheresis was certainly effective and well tolerated. There was a 58% reduction in LDL cholesterol, but there was a 72% reduction in coronary events. So here you see the benefit of lipoprotein apheresis on coronary heart disease in patients with familial hypercholesterolemia. Now, the PRO-A Life study was done to assess the efficacy of lipoprotein apheresis in a high-risk population with elevated lipoprotein A greater than 60 milligrams per deciliter and progressive cardiovascular disease. This was one of the groups of studies from Germany in the German lipoprotein apheresis registry. But in Germany, where they do the most lipoprotein apheresis, you can have apheresis if your LPA is greater than 60 milligrams per deciliter, if there's clinical documentation that you have progressive cardiovascular disease, even with a normal LDL cholesterol. So this study evaluated the event rates for major adverse coronary events. And what I want to point out here, if you look on the left side of the slide, they were looking at events that were occurring 1 and 2 years prior to starting lipoprotein apheresis. And you can see here that the event rate was increasing. Cardiovascular death, non-fatal MI, percutaneous intervention, and need for CABG were all increasing from 2 years prior to therapy to the first year prior to therapy. But what you saw here, that these major adverse coronary events were reduced by 78% after initiating lipoprotein apheresis. So this study demonstrated that lipoprotein apheresis was effective, well-tolerated therapeutic tool in patients with elevated lipoprotein A and progressive cardiovascular disease who were already on maximally tolerated lipid-lowering therapy. So while we know there's no effective pharmacologic therapy to lower lipoprotein apheresis, and we appreciate the fact that peripheral arterial disease is a manifestation of atherosclerosis, we wanted to look at a group of patients that had peripheral arterial disease that were also in this registry of lipoprotein apheresis in Germany. So they were looking here at clinical events, and they had 170 patients, and they looked at the events with regard to peripheral arterial disease prior to apheresis, and they had 30 events 2 years prior to starting lipoprotein apheresis, and this was reduced to 11 events 2 years after lipoprotein apheresis therapy. There was a small group of patients that had carotid artery disease and renal artery disease, and they looked at their need for PCI or surgery, and this was reduced from 7 events 2 years prior to treatment down to 1 event 2 years after lipoprotein apheresis. There were 35 patients in a retrospective cohort that had elevated lipoprotein A, and they looked 7 years back and 7 years after lipoprotein apheresis. And interestingly enough, they found a 90% reduction in cardiac death, non-fatal MI, the need for PCI or coronary artery bypass surgery. They had a 52% reduction in their lipoprotein A levels, and there was a reduction in peripheral arterial vascular events, reduced from 11 events to 2 after starting lipoprotein apheresis therapy. So again, more evidence that in the group with peripheral arterial disease, lipoprotein apheresis is effective. Now, Polar looked at 10 patients that had symptomatic peripheral arterial disease who underwent revascularization and then were treated with lipoprotein apheresis. So their LPA, again, was greater than 60 milligrams per deciliter. They were on optimal risk factor modification, and they showed that with apheresis, the mean LPA was reduced by 67%, and over 24 months was reduced over 55%. More importantly, they looked at the patients in terms of quality of life, in terms of function. They showed that with lipoprotein apheresis, there was an improvement in the walking distance. There was an improvement in the ankle brachial index. There was improvement in the tissue oxygen supply. There was improvement in the pain level. And there was a reduction in revascularization. There were 35 revascularization procedures before apheresis, and then this was down to 2 procedures in the 2 years after apheresis treatment. So lipoprotein apheresis caused a rapid and sustained improvement in peripheral arterial disease symptoms and function, as well as the need for revascularization. Now, another group, again, coming from the German registry here, looking at cardiovascular events over time in patients treated with lipoprotein apheresis. But what was different about this study here, and it's color coordinated for us, they divided the patients into 3 groups. So group 1 had a low LPA of less than 60 milligrams per deciliter, but had a high cholesterol of greater than 100 milligrams per deciliter. Group 2 had a high lipoprotein A of greater than 60 milligrams per deciliter, but their LDL was less than 100 milligrams per deciliter. So group 2 is really looking at isolated effect of elevated lipoprotein A. Group 3 had high lipoprotein A, greater than 60 milligrams per deciliter, and also had a higher LDL cholesterol of 100 milligrams per deciliter. So when they looked at this, group 2, and again, you can look at year 2 into year 1 again for all the groups, and you see an increased number of clinical events while these patients were waiting for apheresis. And the greatest number of events was seen in group 2, the yellow group here, where there was lipoprotein A greater than 60 milligrams per deciliter, but the LDL was, quote, normal, less than 100 milligrams per deciliter. They had an increased rate of clinical events waiting for apheresis. So look at year 1 and year 2, and you'll see in group 2, there was a 70% reduction in major adverse coronary events, cardiovascular death, non-fatal MI, PCI, and coronary artery bypass surgery. So this shows that isolated lipoprotein A was a significant risk modulator for cardiovascular events. Group 3, which was the group that had high LDL and high LPA, had a 74% reduction in clinical events. And the third group, which was group 1, and this was a group that just had high LDL, had a 53% reduction in cardiovascular events. So if you take in together group 2 with a high lipoprotein A and group 3 with a high LDL and lipoprotein A, you see that the LPA, again, is a risk multiplier of clinical events. In terms of where lipoprotein apheresis reduced events, the majority of events were reduced in terms of coronary events, followed by peripheral arterial disease events, and followed by cerebral vascular events. So certainly lipoprotein apheresis was effective in reducing clinical events in this population. Even considering a group of patients with refractory angina and elevated lipoprotein A, lipoprotein apheresis was shown to be effective in that population. 20 patients with refractory angina, LPA greater than 50 milligrams a deciliter were identified for a prospective study, and they were looking at myocardial perfusion reserve measured by MRI. And what they found, and this was a lipoprotein apheresis for 3 months versus sham apheresis, and they found that there was an improvement in the primary endpoint of myocardial perfusion reserve. There was improvement in exercise capacity. There was improvement in anginal symptoms and quality of life, and there was improvement in atheroma burden in the carotid wall measured by CMR. So this suggests that lipoprotein apheresis may be an effective treatment tool for patients with refractory angina that have an elevated lipoprotein A. This is some of the summary analysis of lipoprotein apheresis for elevated lipoprotein A in cardiovascular events. Again, as part of the German apheresis centers, you see 3 different authors, 3 different studies, and what I want to point out here is that all the studies, patients had elevated lipoprotein A. You can see what it was pre and post in Gianos study. It's 118 milligrams per deciliter down to 33 milligrams per deciliter, and that translated into 81% reduction in major adverse cardiac events. Same thing with Rosada, where you had a 70% reduction in cardiovascular events, and Liebman study group here with 78% reduction in major adverse coronary events. And again, you're getting 70% reduction in lipoprotein A, which is what's typical for acute treatment with lipoprotein apheresis. Now, as I said, if you want apheresis, the place to be is in Germany. So the German lipoprotein apheresis registry, short name GLOR, started in 2012. During that time, more than 40% of the patients have been receiving treatment for 1 to 5 years, and approximately half of them have received treatment for more than 5 years. So, with this type of registry, we could look at different things. If you look at lipoprotein A reduction with lipoprotein apheresis and some of the clinical data, we have the registry from 2020, which showed major adverse coronary events were reduced 83% in the first 2 years. I'm going to break down that data for you a little bit more. If you look at the registry sub-analysis that came out in 2022, you'll see a lower major adverse coronary events in patients with so-called normal LDL cholesterol, but having a high lipoprotein A. I'll show you some of the data from Pat Moriarty's group in Kansas, also showing a reduction in major adverse clinical events compared to pretreatment levels or prior to lipoprotein apheresis. So this is, kind of cool. And you can look here again, these are patients that were divided by their LDL cholesterol and their lipoprotein A. So considered high risk if your lipoprotein A was greater than 60 milligrams per deciliter, and quote normal LDL less than 100 milligrams per deciliter. So again, same type of analysis here. You see increased clinical events in the 2 years waiting for lipoprotein apheresis, and then you see an 83% reduction in year 1 and year 2 after lipoprotein apheresis. So you had a median reduction in your LDL cholesterol of 68% and acute reduction in lipoprotein A of about 76%, but you had an 83% reduction in cardiovascular death, non-fatal MI, percutaneous intervention, and coronary artery bypass surgery. This is a summary slide, and again, you can see 3 groups, again, divided by LDL of greater than 100 in the first group here, but the LPA was, quote, normal at less than 60 milligrams per deciliter. You could see group B, less than 100 for the LDL, quote, normal, but the LPA was elevated. And then group 3, both the LPA was elevated greater than 60 and the LDL was elevated greater than 100. So again, look at group B. LPA by itself elevated, 83% reduction in clinical events after 1 year with lipoprotein apheresis. So again, more data and more information reinforcing the benefit of lipoprotein apheresis in these groups at higher risk. And this was a finding in group B, independent of the LDL cholesterol. If you look at group C here, there was a 69% reduction. Again, LPA was high, LDL was high. And then, of course, the first group, LDL was high, LPA was normal. There wasn't such a great event reduction there. Now, this is the latest publication from the German Lipoprotein Registry. It's the 9th annual report. So just if we look at this, same type of thing. The upper left-hand corner is all the groups together. But what they're also looked at here, again, they had major adverse coronary events, which included really cardiac events, CVSMI, non-fatal MI, PCI CABG, and then they had the major adverse non-cardiac events, and this included stroke, carotid PCI or surgery, PAD or renal PCI or surgery. So the Mintz group was different added on here. So if we look at group A, and again, in the upper right-hand corner, this is LDL greater than 100, but the LPA is less than 60. Again, leading into apheresis, you had more events. After apheresis, you had a reduction in clinical events, 42% the first year, and then reduction the second year. But group B, again, to highlight for you again, group B, that's our group with the LPA greater than 60, so the high LPA group, and the LDL of less than 100, and you see 83% reduction in MACE, major adverse cardiac events, and 86% reduction year 2. Then if you look at the reduction in the Mintz, you have 50% and 64% reduction. And then in group 3, where both LPA was high and LDL was high, you have 71%, 78% in coronary events, and you still have 62% and 59% in the Mintz events. So again, showing us that lipoprotein apheresis is certainly effective in this group of high-risk patients. This is data from Kansas University and Pat Moriarty's group. And again, if you look here, and similar to what we see in the Germany group, retrospective analysis and prospective analysis, you see safety data is good. You see patients with coronary events, and you see reduction in MACE of 94% from starting. So international guidelines for initiating lipoprotein apheresis. In North America, it's LDL greater than 100 with CAD, PAD, with or without LPA being greater than 60, or LDL greater than 300. Japan, total cholesterol of greater than 250. Germany, LDL greater than 130, or LPA greater than 60 with progressive coronary heart disease. In terms of guidelines, the 2018 Cholesterol Guideline Committee, lipoprotein A increases atherosclerotic risk, especially in patients higher levels of LPA greater than 50, LPA of greater than 125 nanomoles or greater than 50 milligrams per deciliter is a risk-enhancing feature, and other recommendations from the AHA. The most effective clinical available intervention for LPA lowering is lipoprotein apheresis. Information in the lipoprotein atherosclerotic cardiovascular and aortic stenosis recommendations from European Society. Lipoprotein apheresis can be considered in patients with very high lipoprotein A and progressive cardiovascular disease, despite optimal management of risk factors. So again, it's important and certainly being recognized that apheresis is an important treatment at various aspects all over the world. On the left-hand side are the US guidelines for lipoprotein apheresis, and you have your familial hypocholesterolemia group. The group that's increasing to greater numbers here in the United States is clinically diagnosed FH, heterozygotes with an LDL of greater than 100 milligrams per deciliter, lipoprotein A of greater than 60 milligrams per deciliter, and either documented coronary disease or peripheral arterial disease. On the right-hand side, this is the Canica liposorber machine that we use. Patient 1 up here, everything yellow is cholesterol that we remove. Patient 1's cholesterol likes to coagulate or coalesce. Patient's 2 cholesterol likes to come out in swirls, very artistic presentation, but this is what we remove from the patient with our lipoprotein apheresis. So in conclusion, high-risk patients have progressive atherosclerosis. LDL reduction to target may not be enough for some patient populations. Residual risk manifested by elevated lipoprotein A is a risk multiplier, a modulator, which should be measured, especially in patients with progressive coronary artery disease or symptomatic peripheral arterial disease. There are randomized clinical studies that have begun now looking at CVS event reduction using antisense oligonucleotides and small interfering RNA molecules to reduce lipoprotein A. PCSK9 inhibitors are not indicated for elevated lipoprotein A. We have longitudinal observational studies suggesting that lipoprotein A reduction by lipoprotein apheresis reduces the incidence of cardiovascular events. peripheral arterial disease is associated with elevated lipoprotein A, and lipoprotein A may be a predictor of the development of peripheral arterial disease, and certainly has been associated with worse outcomes in those patients with symptomatic peripheral arterial disease. Lipoprotein apheresis reduced the need for revascularizations and improved symptoms and functions in patients with peripheral arterial disease. Lipoprotein apheresis is the most effective therapeutic intervention to date to reduce lipoprotein A, and lipoprotein apheresis should be considered in clinically high-risk patients with elevated lipoprotein A and polyvascular disease. So I'd like to thank everyone for joining us this evening. I'll be answering questions, and here's your information regarding CME and garnering credit for tonight's presentation. Thank you so much.
Thank you, Guy. That was such a great overview. I'm always fascinated by the degree of data out there on lipoprotein apheresis. I think historically, we've always just thought of this as something that we are reserving for the homozygous FH patient, and not so typically used for the heterozygous patient, not at goal for the patient with elevated LPA, PAD, as you mentioned. So many different categories of patients who would benefit, plus the other benefits that you mentioned, all of them: significant LDL lowering, significant LPA lowering, reduction in inflammatory markers, prothrombotic markers, et cetera, and viscosity. And the MACE, is very hard endpoints that you're describing how much you can reduce heart attack, stroke, cardiovascular events, et cetera. A lot of people criticize the data, though, saying, well, it's observational data, though. So how can we, unfortunately, this is what we have when you have a procedure. You're not going to have sham trials set up, all over the place looking at these things. But it's still very, very impactful data. So thank you so much for sharing all of this. My first question, and then I'm going to go to the questions I see just popped in there. My first question is about essentially PCSK9 trials. So you mentioned that they do not yet have an indication for LPA. There is no indication out there, although they do lower LPA. What do you make of the data? How do you interpret, what we know about the effects of lowering LPA with respect to PCSK9?
Well, I think it's interesting. We don't know really, the exact mechanisms that PCSK9 lowers the LDL or LPA rather. We can speculate. What was interesting within the data, while it's 14 to 30% reduction, they showed that the patients that had the highest LPA had the least benefit in terms of clinical event reduction, where the patients with a lower LPA had not event reduction, patients with the lower LPA had a greater reduction in PCSK9 effect on the LPA. The patients with the higher LPA had a lesser effect with PCSK9 treatment. So, we'll still, work out the mechanism for how that could occur. And maybe, as they look in future studies, may have a benefit on LPA and clinical event data.
Yeah, I think the Odyssey trial and the sort of retrospective look at it and everything, for the most part, looked like those with benefits, specifically the highest at baseline and with lowering, did show benefit, which I think just sort of argues that if we can target LPA, as you're saying, with apheresis, as has been shown, it's the only one out there, you obviously get the much greater event reduction that you're showing in all of your slides, essentially, which is really important. Question from the audience, a very simple one that I know you can handle, commenting on ACE-ARB therapy and apheresis. What should people do if a patient is on an ACE or an ARB?
Yeah, I think that's a great point. So patients who are on ACEs or ARB should hold the ACE or ARB at least a week prior to treatment, because of bradykinin effects. You can have greater drops in blood pressure. So we have one patient that was on an ACE inhibitor, and it was a low dose. We were able to change her onto something else. But being on an ACE inhibitor is a contraindication to lipoprotein apheresis. So be aware of your patient's medications before referring for lipoprotein apheresis.
Exactly. Another question about coverage, insurance coverage for lipoprotein A, as well as apheresis. LPA, I'll mention very briefly that, depending on the insurance, some will cover, some will not. It's the cost to the lab is approximately $5, as we sort of reviewed this morning. Sam Samikas was giving a talk. And the truth is that a lot of labs, what they'll do is, just sort of cover, in some institutions, cover those that are paid for. And, unfortunately right now it's not a universal coverage. So it's not always covered. And in some cases, a patient could get a bill. The actual cost is low, but depending on the fee, a patient potentially could get a bill depending on where they go for the LPA. Apheresis, do you want to tell us about coverage there, Guy?
Yeah, I mean, for our patients, everything is predetermined before we, initiate apheresis. And I think, I can show you here on the prior slide, here are the 4 groups that are easily covered by lipoprotein apheresis. We have one patient who's homozygous, familial hypercholesterolemia. We have one person who's heterozygous hypercholesterolemia. So the growing indication, as I said, is clinically FH type patients, LDL greater than 100 on maximally tolerated statin therapy, and a LPA of greater than 60 milligrams per deciliter, and having CAD and PAD. So as I said, these patients are having recurrent events, have the high LPA, and unfortunately in our country, you need to have the LDL greater than 100 to be a candidate for apheresis. So, really, if they're meeting those categories, we've had no trouble getting insurance coverage. And if you are doing apheresis, certainly there are, third parties that will help you obtain the insurance certification.
Exactly. And they asked about documentation in the note. So I guess essentially all this, and then the events.
Yeah, you need to have the PAD, the CAD, you have to have the maximally tolerated therapy, and the LDL still persisting above 100. But I do want to say something. One of our patients that we do treat is on maximally tolerated statin therapy, which is rosuvastatin 40, is on PCSK9 therapy, is on bempedoic acid, is on ezetimibe and evinacumab, and she still comes back each week with LDLs of greater than 160, and this is someone that had coronary artery bypass surgery in the 40s. So even though we have very effective therapy for LDL reduction, there are a group of patients, as I said earlier, that hypercholesterolemia, familial hypercholesterolemia, is itself a risk modulator for clinical events. So there are groups of patients out there that certainly benefit. And for this particular patient, she had xanthomas all over her body. She was not able to drive a car. And within 9 months to 12 months of apheresis, she's actually been able to drive a car for the first time in 10 years, as the xanthomas have been resolving in the lower extremity.
Yeah, that's a great example. Because I think a lot of people question whether there really is a need anymore for apheresis as new therapies are coming out, right? And you're well aware of all the therapies, and in your patients that, have made it to apheresis, clearly you've exhausted every single one of them, and they're still requiring this apheresis. And to the extent where it's really changed their lives, I think that's really helpful to see. And I think that a lot of people think of this a little bit as an invasive process, and, we don't really want to subject people to having to go in. I mean, the reality is when you have a port and it's, a couple of hours and it's on your schedule every 2 weeks, we can make these experiences be very favorable for the patient and well worth it, because you get all the additional benefits, as you mentioned, of reduction in inflammatory marker, prothrombotic markers, et cetera. So clearly you've seen that it's worth it. I have a question for you, because I know that you work with quite a few other services. So you describe so many of these very high risk patients, and we know they're out there. So any thoughts for the clinicians? How can we recognize more people who are at high risk, who really need more optimization?
Yeah, I think that's a great question. And if you took anything away from tonight's discussion, the group with peripheral arterial disease, especially symptomatic peripheral arterial disease, has a very high risk for cardiovascular events. So I think it's important for us to reach out to our colleagues in vascular medicine, vascular surgery, and educate them. And as I said, these patients having progressive symptoms are at high risk. A lipoprotein A measurement should be done and help identify those patients even at greater risk. So I think the answer comes from education, whether you're doing grand rounds for them, whether you're just having clinical case presentations. Education is the key.
Great, excellent. And that's actually one of the next questions, was how we most effectively get our interventional general cardiology vascular colleagues to recognize the need for LPA. And I think exactly like you said, LPA testing, that is exactly as you said. Number one, you create relationships with these teams of people where they know exactly how good you are at getting the patients to goal. And so they are sending you those high-risk patients. I think it's partly like Dr. Mintz said, getting the grand rounds, getting the education out there, working with them closely, even if it's curbsiding. I think then they start to learn exactly what you do. And I've realized now that every young acute MI, they're getting the LPA checked and they're calling us early with patients that potentially would benefit. Another question is just about using lipoprotein apheresis in focal segmental glomerular sclerosis. So, in terms of that indication, I know that there is data, obviously, similar observational data that does show improvement in kidney function and with using this. So this is a select group of people who end up using the apheresis short term for this purpose. And it's also underutilized as well. So something important to keep in mind.
Yeah, and I'll just make another point about what we're talking about and getting the word out to our colleagues. So for instance, in New York State, there are only 3 centers that are doing lipoprotein apheresis. One is, upstate in Rochester, one is in New York City, and we're the only center, on Long Island, drawing from, surrounding areas. So I think it's not only a question of getting the word out to our immediate colleagues on campus with us, but I think as clinicians, we need to get the word out to a greater community, and maybe forums like this where we can, have a greater outreach, because certainly there aren't enough centers, and people can go to the familial hypercholesterolemia, groups or the Family Heart Foundation, and find centers. But I think we need to get the word out throughout our surrounding area.
That's exactly right. Dr. Mintz and I have colleagues throughout the country who have patients who will travel up to 2 hours to get to their site because it's the only one available within that distance, and it's that worthwhile. And as he mentioned, the Family Heart Organization has a website, and you can go there to see in the country all of the sites and where the nearest one might be to where you're practicing. But yes, this is, over the past, 10 years or so, I've seen a greater awareness of the other types of patients that benefit here. It's not just the homozygous FH patient, the peripheral arterial disease, the stroke, young patients with stroke from LPA elevation, patients who were having recurrent events very often until the need for this was recognized and improved their outcomes. So I think this has been a really big, eye-opener for me over the years, and something that really changes the outcome of our patients. So thank you for walking us through all of the data specific to apheresis high-risk patients. It was an excellent talk. And thank you to our audience for joining us tonight. Again, this is the way you get credit, as you see on the screen, for participating today. And it will be available again. We'll try to circulate it, and you can share with others. So thank you so much, Dr. Mintz. Appreciate you joining us.
Well, thank you, and thank the audience for joining us. Appreciate it.
Good night, everyone.
Good night. So are we isolated again?
No.
It's just you and I and Jen. So Well
Thanks a
done.
lot. Leslie.
Very well done.
Yes. Thank you.
You know, I think you and I make the tag team. We can go out on the road.